I briefed Alim because he has to talk a lot after that. So we have a very good team. Dr. Amrit Patjoshi Bhubaneswar is the moderator, a neuropsychiatrist, psychotherapist, and wellness consultant. He is professor in High-Tech Medical College and chief consultant in Amini Hospital and Healing Touch Clinic. He is a direct council member of IPS and editor of Odisha Journal of Psychiatry, which is indexed. He had been the chief coordinator of UNICEF WHO and IPS initiative on telemedicine and psychosocial management during COVID-19. And in our team, there is Dr. Aleem Siddiqui of Lucknow, Nawab Aleem Siddiqui. He is the director of Healthy Minds Neuropsychiatry and Behavioral Science Center, Lucknow, visiting professor of psychiatry, ERAS, Lucknow Medical College and Hospital. He is also a direct council member of IPS. He is a guest faculty in Trinity University. He is finance secretary of IMA Lucknow and also IAPP UP, UK chapter of IAPP. And in our team, we have got three other persons, Sajia, Sarda, and Rucha. I would like to take their names today definitely because today is our Silver Jubilee edition. And my heartiest compliments to all of them. And our chairpersons, esteemed Dr. S.C. Tiwari, who is also from Lucknow. He had been the professor and head of the Department of Geriatric Mental Health in KGMU, Lucknow. He had actually founded this department. His present designation is Chairman, Mental Health Foundation, Lucknow, Uttar Pradesh. And previous designation, Professor and Founder, Head, Department of Geriatric Mental Health, Chief Medical Superintendent of Gandhi Memorial and Associated Hospitals, KGMU, Lucknow. Additional responsibility he had held ex-Vice Dean, Center of Advanced Research and Training, CARDS, Secretary State Mental Health Authority, Government of UP, Lucknow, Chairman Subcommittee of Mental Health in State of Uttar Pradesh, Vision, Chairperson Geriatric Psychiatry Specialty Section of IPS. He had been awarded Tilak Bhinkavara Oration Award and recipient of BBCT Oration Award of IPS Central Zone and Marfatia Oration Award of IPS and many more. With this, we have with you the veteran, legendary Dr. S.C. Tiwari. Welcome, sir. Dr. S.K. Deuri, my dear friend, who is the director of LGBRIMS Tezpur and professor of psychiatry in that institute. His professional affiliations are Secretary, State Branch of Indian Psychiatric Society, President, State Branch of Indian Psychiatric Society, Executive Member of East Zone Branch, Co-Chairman of Mental Hospital Subcommittee of IPS, Chairman of Mental Hospital Subcommittee of IPS, President, IPS East Zone Branch, Member National Mental Health Policy Body, Consultation Committee on Mental Health Care Bill, Member of Academics Committee of Guwahati University. His special area of interest involves forensic psychiatry, rehabilitation, and mental health planning. And on this occasion today, I take privilege to welcome and offer best wishes on the occasion of this. Today, Makar Sankranti is celebrated in different parts of India by very various names. It is Lohri in Punjab, Makar Sankranti in Bihar, Jharkhand, Magh Bihu in Assam, Northeast, Khichdi in UP, Uttarayan, Gujarat, Rajasthan, Makar Sankranti here in Odisha, Maharashtra, MP, Lohri, Makara Sankranama, Makara Bikau, Pongal, Posh Sankranti, and Shishu Sarkrant. So many names, one day celebration. This is celebration day today. And on this day, we are celebrating the Silver Jubilee. I have taken 2 minutes more time that I had shared from Aleem. And with this, I hand over that meeting to the chairpersons, Dr. Deuri and Dr. Tiwari. You stays, please.
Good evening, everybody. So greetings from Tezpur. So Dr. Pati has already told is a close friend, but more than that, I thank you very much for inviting me to be a part of this discussions today. And he does not, I think Dr. Pati is known for his military precision. For last so many days, you must have seen the flyer. He has been in touch all the time. And now today is a Magh Bihu day for us. So Sankranti for all of you. And I am very happy to be in a subject which is, I think we are closely inching towards that area. So last few days, it was interesting to notice that it was amusing. So I thought that there will be a lot of reflections, contemplation, and the chances are very high that boundaries will be expanded when the discussions are on. So as a chairperson, I'll just, we have two chairpersons here. One is already Professor S.C. Tiwari, all of you know him. So I'll leave the conclusion parts to him. So the summarization, I will invite him to do the summarization because he has a fair degree of expertise in this. And he is one of those leading doyens in geriatric psychiatry in this country. So now, I know that we have a very eminent speaker in front of us. We are going to listen to him very shortly. But even before we proceed further, I'll try to take you through some of those, because it's called musing. So I'm taking the liberty of breaching the boundary. It's a clinical boundary to some extent. It's like last year, particularly, because of COVID, all of us must have gone through all those that experiences which were very demanding on us. It was very challenging. What has happened is, I always kept on saying that as the physical, actually, though we have kept on saying that it's a social or physical distancing, but what has happened in many parts of this our country, because of the closeness of people in a house, the proximity has become more marked. It was not physical boundary of 6 feet, has become more than a, because it was not possible in many of the places. So what has happened is, in last few months, we have seen that many of those people who seem to have been very, very keen, very much engaged in taking geriatric care of the elderly people in their households, started feeling a pressure of a different nature. And things have changed dramatically in many of these families. So that was one very interesting areas which we have noticed. But anyway, we have an eminent speaker who will be telling us more about all this, and I'll just briefly try to introduce him. The Professor Nilamadha Kar is fairly known all around in this part of the country because he's being from his zone basically. So he is a consultant psychiatrist in Black Country Healthcare in the National Health Foundation Trust. He is a college tutor in postgraduate psychiatry training in Wolverhampton. He is the guardian of safe working, lead for cardiometabolic screening and intervention for persons with mental illness. He is a member in research and innovation department. He is a mentor in the Royal College of Psychiatry, West Midlands Division. He is a facilitator, a leadership course, the course trainee in psychiatry, West Midlands in the United Kingdom. And he has extensive research interest in post-traumatic stress disorder and disaster mental health, geriatric mental health, and preventive psychiatry and clinical psychopharmacology, which already put up, I think, in the slide for everybody to see. So I will not take the time because it's already there, and we will be running through some time gaps later on. I'll request Professor Kaur to start with the presentation, and later on we can have a discussion on this. Thank you very much for giving me this opportunity to introduce such a prominent speaker for all of us. So I'll request Professor Kaur to start the presentation. Thank you very much.
Thank you, Professor Deore, for your kind words. It's really, really appreciated. I was a professor, associate professor in Manipal long back. I'm not now associated with universities now here. So just doctor is fine for me now. Thank you. And thanks, Dr. Tiwari, who is other chairperson. He's, we have interacted, I don't know whether he remembers, He is in the editorial board of the Journal of Geriatric Care and Research that we edit from 2014. I must thank Dr. Pati first before I start my presentation. He actually invited and suggested the topic, which is so close to my heart. Thanks very much, Dr. Pati. And I think that was really helpful to, to choose that. And Amrit, I know from a long time. Amrit and Alim, thanks very much for inviting me and having me here. I'll now share my screen to, let's see, where is it? So that's the topic, family as caregiver in psychogeriatric practice, a comparative case vignettes. I think that's the credit of having case vignettes goes to Dr. Pati, because he suggested that it's better to have some comparative, narratives, which will actually bring home the more. I think that's a really good idea. I think in my presentation in next 40-45 minutes, we will visit some of those, so it will make it more closer to what we do. The plan for next 30-40 minutes would be something like this. We'll refocus on the situation. We'll highlight the carers issues, which is already kind of known. Impact of caregiving on carers and what can be done about it. And towards the end, we will discuss some take-home messages. And at the very end, obviously, please share your ideas, views, and experiences, because everybody here is an expert. I may not be saying anything that you do not know already, so excuse me for that. But I think I'm just interested to encourage a debate or basically a discussion, and to share your ideas and views. I have worked in India. I'm working now for some time here. So I've seen kind of both worlds. So maybe we can share things, what is happening in different parts of the, this world. I know most of us are approaching 60. Some of us are already above 60, which is a kind of cutoff in India still as elderly. And some are far away from 60. They're still very young. So let's have some warm-up questions, warm-up areas to get into the topic. So how likely that you need care in your old days? Just think about it. We could have done a kind of automatic question answer type, but I think that it is late for that. So whether it's most likely or least likely.
Is Pawan, is it possible now?
Hello.
Question answer, is it possible now? Pulling?
People can just simply respond or write what they think.
Can you share the question to me on chat, sir? I'll just,
just go back to the
poll out of it.
The participants are requested to write A for most likely and B for least likely. How likely that you would need care in your old age? A most likely, B least likely. A or B?
So that's a good way.
आपका समय शुरू होता है अब और समय खत्म भी हो रहा है अब जल्दी से डाल दीजिए.
Thank you, Alim. Thanks very much. Now, basically, do you know?
A has one hands on. No B, only A.
Only A. Okay, most
Yes,
likely. So
most
that's
likely.
good. A lot of people are really thinking they will be needing care, isn't it? And which is basically a fact. And do you know, those who are thinking they may not, you are already receiving care. You know, some people in your family are taking care. That's why you are properly dressed up, ready for this meeting. You are here. People are supporting each other in the family, isn't it? It's a component of life from the beginning, and you will need it more when you grow older. So there is no doubt about that. Now let's go to the next question. How many of you would like to live in a care home or old age home when you need care? Alim, we can do ABC.
So yes, sir. So the question is for the audience, please type in how many of you would like to live in a care home or old age home when you need care? A, not at all. B, probably. C, yes, absolutely. So A, B, C. How
भी
many
type
of
कर
you
अलीम,
would like?
तू भी type कर.
So the interesting point is this is becoming more common, even in India. You see the old age homes are coming up, or care homes, and some people are moving into them. Whether they like it or not, we will see what the research say. Is it by a reason, by a choice, or something that people move on? We will discuss that in a minute. But that is becoming a reality.
There is
Obviously,
a split between A and B.
Alim, you have some answer there?
Yes.
It is a split between A and B.
No, I
Oh.
think majority are B. Majority are most are B.
Most are B. So
Majority
most
thing.
people are saying probably they will go. So that is already there in the mind, isn't it? So there is that's a point. Okay, when you are in that age, you know, who would you like to be your, most likely would be your carer? Your spouse, your son, daughter-in-law, daughter, son-in-law, grandchildren, or sibling? Or you want a hired nurse or paid carer for it? Obviously, I do not want you to respond to that with A, B, C, D, E, but I think most people would like in this kind of, spouse to be there or life partner to be there and all that. But many of us will be alone at some point of time because spouses will not be able to do that or not able to continue. So it will become a problem there. So if you see the really oldest old, most of them could be really alone and being taken care of by somebody else. Now, these exercises that we just did actually is helping us to focus that it is not just about our patients and their relative or their family. It is something inevitable fact of our lives as well. So we will be needing care. Thankfully, I would like people should remain healthy. But as you know, in old age, multimorbidity is common. We'll look into those things. So what is needed at the moment is refocusing. Patient has always been our center of all that we do as clinicians. And we remain focused with that. And we just take it granted that it is being supported and all, and family would support that. And kind of we almost stop there. Obviously, it's not that by design we say we don't see them, but actually maybe we're too busy. We don't have time for those things. We are extremely busy, obviously. Now we have to refocus. We have to see the patient that we are seeing, who is actually taking care of them at home. If you see a patient who is elderly, 60 plus in India, somewhere it is 65, and obviously that definition changes at different places. But if somebody is an elderly with a psychiatric problem, who is the person who is taking care of them? So, and if we know, and that is actually the crux of this today's presentation or discussion that we have now. So let's see. You may ask at the moment that why should we as psychiatrists would be bothered about caring? My return to that would be who else? Because we are the ones who know about stress, know about depression. So whether elderly has a psychiatric problem or not, whether it is a physical problem, cancer, problem with other things, still the carers will be stressed, depressed, and we'll see all those things now. But we will focus on the psychogeriatric, mostly this study, what is available, mostly on dementia actually, where there will be a lot of different things in old age, but most of the studies actually center around dementia. But that is about the patient. We will be talking about the carers who would be obviously stressed, depression, and who else other than the psychiatrists know these kind of things best. So what we already know is that longevity is increasing, elderly population is increasing, number of people with mental health problem is actually increasing with depression and dementia, and the adult children are living away, most of them. I'm one of the examples. So, and busy, most of them are busy in their works, very difficult, they're not able to, not having time to spend with their parents, and more elderly are living alone. And that's happening from India. Most of these references are from India. Loneliness, helplessness, and stress is growing in elderly. And what about the social activity, the interactions? It's all going down to TVs and phones. And in obviously this last whole 1 year has seen us how we have been affected by Corona. So what do the numbers say? It's focused on India. You know, in 2020, just gone, India had a population of 138 crores, which is around 20% of world's population. And amongst them, the 60 plus were around 10%. So 1 in 10 now, in 2018, of course, were like aged 60 or more, like elderly, the definition of elderly in India. Now, life expectancy obviously has gone up. I need not go into that. And it is going to increase the proportion of elderly in India to almost 19 to 20% by 2050, which is what is happening in developed countries. But by sheer number, this is huge. You know, the population in developed countries may be less, so the actual number of elderly will be there less. But even if 10% of elderly in India, we have a huge population, and all these people need care. If you see our psychogeriatric population, it is almost, global prevalence was 5 to 7%. And the Kerala study, famously done by one of my friends, Saji, is 3.2%. And if you see in 2015, around 4.1 million persons were having dementia in India, which may actually go up to 1.3 crore by 2050. So it will massively, it is increasing because longevity is increasing, age is a factor for dementia. So I'm just trying to highlight that how much care needs are increasing. Coming to depression, median value around world is 10.3 in elderly, but in India it is 1 in 5 in 2011. This is the Borua et al. Study, which I was a co-author. And now I was checking, it is almost 35% in 2019. So many people are depressed in old age. So there was an interesting study in Bradford, UK. They studied the people from Indian subcontinent, like Pakistan, India, and Bangladesh. Depression is very comparable, 20%, dementia 4%, and anxiety neurosis 4%. So this is kind of how the distribution of psychogeriatric diagnosis in the elderly. And if you see the socio-demographic scenario for the elderly in India, 6.6% of elderly female and 1.6 live alone. There is no carer. So, and this is a very, very recent data, recent information. 75th round of National Sample Survey, I think in 2019, late 19, it was completed. So, and almost 1 in 4, more than that, above 80 are immobile. So you can imagine the amount of care input that is needed. And 50% of male and 90% female are financially dependent, and only less than 1 in 5 have health insurance. So if they have emergency healthcare, it will be a really problem. Now coming to, this is if you understand what is the magnitude of the problem that we are facing now. And you imagine most of them are in their families and families are taking care of them. They're not in old age homes or care homes or anywhere else. Okay, most of them are in their families. Now, what are those carers' issues? Whether they like it or not, the choice isn't there for most of them, and they do take care in whichever way. We'll see the issues now. Let's go for a case description. Simran, 74-year-old, who lives with her husband and son and daughter-in-law, and a 3-year-old granddaughter in Pune. Her husband, who is 81, has a history of diabetes, hypertension, ischemic heart disease, and has multiple bypass operation around 7 years back, has cataract surgery, history of falls, and he recently developed difficulty in vision. He has been diagnosed with multi-infarct dementia. He sleeps more in the day, less at night, roams, goes into son's room, suspects, shouts at people, recently started exposing. He takes multiple medications 3 times a day and visits consultants in different hospitals almost every other month. Simran takes care of husband. Son and daughter work, so daughter-in-law work, so she takes care of granddaughter as well. Does it sound a very similar kind of the story that we see with our patients? We spend more time in understanding our patients. We just know who is taking care. Sometimes it is granted that the wife is taking care. And she herself is 74. You know, she would have her own issues. So let's see what are the care issues. She has to support for her husband's activities of daily living, taking to bathroom and all those things. Caring for falls, the roaming. He is going around agitated, so it is she who has to get up, even middle of the night. He is taking multiple medications that needs sorting, so she is the one who has to do it. She worries that what will happen in emergency. She is aware of 108, you know, but she wonders whether the ambulance will come, whether they will reach in time. She suffers from various illnesses and feels tired. She feels guilty that she's not able to take care of her husband well, feels she's not able to do that role properly, feels upset and sad. No meaningful communication with husband, because husband is simply sometimes not recognizing, so she feels lonely. No time for herself. She doesn't attend family functions. And she also takes care of the granddaughter as well. So this is the story of a person there. Now see another case from here. 81-year Natalie lives with her 89-year-old husband, Mike, in Reading, UK. They live in a bungalow. Her son and 2 daughters live in different cities. They're not living with them. Her husband suffered from Alzheimer's for last 7 years. Currently, it is a severe degree. He also has diabetes, hypertension, and incontinence. He sometimes wanders away. Natalie has hypertension, vision problem, cataract, arthritis in knee and hip, and is waiting for surgery. Now, what are the care issues here? Their medicines for Mike and Natalie are delivered at home by dosette boxes. All, you know, which time they will take. It is already packed, day-wise, time-wise. They just have to open that particular box and take it. She prepares food sometimes, but they depend on meals and will. Somebody comes and delivers hot meals or cold meals. A respite carer comes to their house, attend Mike, you know, takes care of almost 3 times a week. And sometimes her granddaughter takes care in the weekends. And when she goes out, a local, for a few days, a local care home takes care of Mike, her husband, as a respite care. Okay. And Mike has a gadget which alerts telecare. Suppose he wanders away, that gadget will actually inform office saying that this person has gone out of his house. So they will come out and bring him back. Natalie visits Alzheimer's cafe in the city. She knows she can call 111 for advice and 999 in emergency, and she believes it will come in few minutes. But she also worries if Mike's condition deteriorates further, he may need a care home placement. It may be too costly, and how it will be funded, where they will get the money. But this is, you know, comparative. The worries are there in India as well. Worries are here, but it is a bit of different kind of worry. But the actual physical input, emotional input of caring is still much more in India. A lot of family members do a lot more actually in India than here. Caregiving is a positive experience. Unfortunately, in most of the studies, most of the research, you see the negative side of caregiving. That caregiving is stressful has been highlighted. Now people have recognized that this is a positive experience. It can be associated with happiness, is very enriching, And there are a lot of positive constructs like spirituality, resilience, and other things. And these needs to be studied. Amongst us, those who are listening, if you're interested, if you're doing any study on caregiving, do include some positive aspects as well, not just the stress, depression, and all that. Interestingly, it is associated with happiness only when it is less than 6 hours a week. That means not every day. You can go up to 6, like 1 hour a day for 6 days. Then more than that, it becomes stressful. When caring becomes stressful, maybe being responsible for all the while, long hours, no rest, no adequate sleep, the work and hobbies and social activities are affected. There's no scope of sharing, no choice, no time for self. We all know these things, that it becomes stressful. And another interesting thing, when there is a poor communication with patients, if the patient is dementia, not able to remember, not able to have an interesting conversation, sometimes not even able to recognize, and most of them would have hard of hearing, so people don't communicate. So the distance grows, and most of the caregivers, being spouse and sons and son-in-laws, they feel distanced and obviously stressed and depressed. Well, who is a typical carer from the research? It's a female most of the time, and in India it is daughter-in-laws. Little more than 50% of them are actually daughter-in-laws who take care. Most often would be spouses, housewives, and all that. And they are most of the time tired. They have poor sleep. They don't do exercise. They don't. Their socialization decreases because they can't leave the person and go out. So it becomes. This is the typical carer. When it is very senior elderly, they are taking care, like 80 plus, oldest to olds and all that. The carer's age is also in the elderly side most of the time. You know, they are also like 60 plus, 70 plus. And around 20% would have their own fair and poor health themselves. So this is a Western study, American study, but I think the same can be there in India as well. And most of them do more than 8 hours per day, taking care of them, the oldest old. So what are the impact of caring on caregivers? Now, as I mentioned, most of these studies have been done in dementia patients, okay? And those who are here interested to do any study or to know, I think I would suggest do it also on people who are having depressions, elderly with depression. Depression is so common, and taking care of depressed elderly is also a challenge, not just dementia patients. So around 15% of them would have depression, but the number varies to almost 40%. You know, in different studies. And caregiver burden and depression are obviously positively associated. That means if you are more burdened, you'll be more depressed. So what are the predictors of caregiver stress? Severity of patient illness, memory loss, movement restrictions, immobility, loss of perceptions, all those. And if they have a behavioral problem as well, along with Alzheimer's disease or dementia anyway, and if they are young, like less than 65, you know, the patient's age, then the stress is much more. Obviously, pretty understandable. What are the predictors of depression in caregivers? The primary caregiver, the person who is solely or mostly responsible for it. And if the dementia is severe, if there is behavioral problems, lower education, and the spousal caregivers. Spouses obviously become very stressed, or they become very depressed, seeing their spouse actually getting distance, not able to interact, being away and away emotionally in any way. What is the intensity of caregiving and transitioning? There is this interesting study I wanted to just touch upon. One is that if the higher intensity of caregiving, then higher stress is there, very understandable. And non-caregivers will have less stress, fine. But if you start having low to high intensity of care, if the care needs increases, the stress becomes higher, which is pretty understandable, but people have done studies to prove that. Caregiver burden and quality of life. This is a Lucknow study, Alim, and it was done by Srivastava and Dr. Tiwari is also a co-author, and I thought I'll specifically mention this. So in this, they have studied or found that caregiver burden and quality of life, all caregivers had a mild to moderate level of burden. And that obviously linked to a lower quality of life. And there is a negative correlation between burden and quality of life, which is pretty understandable. If the burden goes up, then quality of life goes down. And they suggested the professional help is needed and supportive psychotherapy for key caregivers. Very, very learned suggestions. They have almost gone and they need professional help and supportive psychotherapy. So which has been actually repeated again and again, you'll see in so many different studies. So it's a pretty interesting one. Caregiver of dementia in an Indian village setup. Let's go to South India, Tiruvannamalur in Tamil Nadu. There the caregivers, strongly felt that caregiving is an integral part of Indian culture, which is, I think, very understandable. We do take care of our elderly. And elderly prefer this home-based care. They don't want to go to the old age home. Unfortunately, as I mentioned initially, the old age homes, care homes are coming up. I think the builders now also trying to woo people that, oh, it has all the facilities for old age, so you come and buy those kind of properties. But then elderly actually prefer to stay in their own home with their family rather than go to a old age home. Caregiving interferes with their personal and professional life, the caregivers, which is very understandable. Some actually have to stop working or stop doing what they want to do to take care of their family. They are not adequately trained in caregiving, the carers, the informal family caregivers who are actually, most of them are obviously not trained, and they need help in those things. Now, there is a study in Niemann's, which they had care in the geriatric clinic with the groups of, they've taken the groups of people who were attending the elderly there, family members, and they found these kind of issues with them. A lot of people, carers, emotional and cognitive responses have been anger, being sad, frustrated, embarrassment, all those things, which is pretty understandable, being in a stressed situation most of the time. And they were very concerned about the patient future, whether this person will be able to take care of themselves, go to bathroom, eat, groom, take care of their personal hygiene. And many times elderly are also very worried that whether I have to depend upon others, which will be a issue with the dignity as well. Whether they will be able to take care of household responsibility, whether they will be able to socialize. These are the carers' concerns. When we know all these things, maybe we can help them better. The other things about female spouses who are carers, they were thinking the burden of increased responsibility. Now, the kind of responsibility they have not taken in their life, now that they are taking care of an elderly who has dementia or depression, not able to do a lot of things, so their burden has increased. Difficulty in understanding erratic behavior, and loss of the breadwinner, if it is, this is the person who was actually helping financially. So, and there is different in male spouses. If they become carers, they obviously find it difficult with the household chores. They have not done that in the whole life. Now, when they are taking care, they have to do that. It's pretty interesting. So, elderly male Indians should now pick up some sort of household chores when they are going along. So prepare for a caregiving role. So there are loss of routine and difficulty in understanding erratic behavior. Those things are also there. Now, what are the other issues to consider when we are seeing caregivers, family caregivers who are not trained, and they're taking care of people with challenging behaviors with dementia, depression, and other psychiatric problems. Multimorbidity, like elderly means there will be psychiatric problems and there will be definitely a lot of physical problems, okay? And this becomes more and more challenging. They have to take care of the physical things and psychiatric things as well. And it definitely needs more resources, more management. And there is stigma is still very common. And because if somebody has dementia, it has been already said that they don't seek help in right time. ASEANs here in UK, they take time. Burnout is very common in caregivers. It affects the quality of care, if nothing else. What is the burnout syndrome in carers? Let's see, that there may be emotional exertions, depersonalization, or reduction of personal fulfillment. Their own things, obviously, they are not able to do. And it negatively affects their life, quality of life, and it's associated with patients' depressive and anxious symptoms. If patient has more depressive and anxious symptoms, obviously burnout will be more. You can imagine say, depressive elderly with no motivation to do anything, and the carers might be spending all her or his time to encourage him to do few very basic things. More importantly, there is an abusive behavior by the caregiver. When they are burnt out, the caregivers, their behavior may become abusive towards the person that they should be taking care. Okay, so elder abuse is a very common thing. It's happening, very painful, but it is happening. And when actually the carers, and most of the time the abusers are the family members, and they have the caring responsibility, but they are burnt out, they can't take care, they are not able to understand. So it actually has been proven when there is more stress, abuse goes up. Stress can be for various things. It could be financial stress and others. Or if there is more disability, the likelihood of abuse also increases. So unfortunately, in India, the recent literature says most of the elderly say that they feel abused, whether it is emotional abuse, financial abuse, sometimes physical, but this is happening, which I think as clinicians, as psychiatrists, we need to be pretty much be aware of it. But with all these worrying things, what should be done? What we can do really? What are the interventions? As the flower, it should be multi-layered. Lot of things should be there. Lot of things should put together. Not one solution will fit into this kind of complex problems. So we'll see what kind of what can be done. Let's go to a case. Bijan, 62, lives in Calcutta with his mom and wife. His children are away. His mom is 89, bedridden for 2 years following a fracture of femur. She was operated, but it didn't heal well. She also has diabetes, hypertension, poor memory, difficulty in hearing and seeing. She sobs regularly, asks God to take her away, is irritable, refuses food and medicines often, has been diagnosed with depression. She has lost her husband almost a decade back. Bijan takes care of his mother. His wife doesn't feel comfortable doing that, but helps sometimes. His brother's family live in Kolkata, occasionally visit and spend some time, but do not take caring responsibility. He tried having a paid carer to come and take care, but it didn't work out. The accommodation and food for the nurse or the carer is to be taken care of. Besides, the cost was high, and he was not sure of their training. Sending her to an old age home was also suggested. The condition of the old age home was not good, and he could not afford better ones. Anyway, he didn't want to shift his mother to an old age home, and mother also didn't want actually. Now, how can Bijan be helped? He is the person, 60 plus, he's taking care of his elderly mother, obviously hardly any support, although family members are trying to spending some time, but it's not there enough. The issues are there's not a female to take care of the elderly lady for her personal hygiene. The issue of dignity comes in. The financial constraint, they can't send it to a nursing home or old age home or something like that, or even can't keep a nurse. A lack of a trained carer, that's another thing. Is Bijan stressed and depressed? Quite possibly, yes. But when we see, maybe we see mother for depression, but Bijan is always in the background. Bijan doesn't come, doesn't interact with the psychiatrist to tell his side of the story. So we don't see the caregivers. So we need to actually broaden or refocus our vision to include the caregivers so that we know more about them. And definitely we can help Bijan. See one more case, a vignette, which is Jack, 68, lives in Liverpool, takes care of his father who is 93 and has dementia, diabetes, hypertension. He's mostly bedridden, but can be helped to go to the bathroom. Now he is visited by his carers 3 times a day. This is from social services, who takes care of his hygiene, bed, and food. His accommodation has been modified following suggestion of occupational therapists. So the trip hazards have been removed, like he will not have a fall. He is registered for telecare. As his condition is deteriorating, his consultant psychiatrist and social services are discussing for a care home placement and related funding. Jack is worried and expects that the cost may be borne by the social services. And the care home is within or near Liverpool so that he can visit him often while he carries on with his life and hobbies. So here what is happening is social services and all other, there are other system is trying to take care of the elderly, while the other people, family members can still lead their usual life. Care related to this observation, expert carers are available in the system. There is a multidisciplinary approach, but there is delay in getting the care plan sorted. That's the Jack's worry. And obviously there is financial worry. So again, like the previous two examples, there are worries for caregivers here, there, everywhere, but they may be different in nature, and they all need to be helped. Now, what else can we do? What WHO recommends in their integrated care for older people, ICOP, guidelines, and there is one specific one for the caregivers. WHO suggests that psychological intervention, remember the study from Lucknow, psychological intervention, training and support should be offered to family members and other informal caregivers, those for those people, elderly people who have mental health problems or those who are care dependent. And intervention for caregivers, actually three main themes comes. One is basically informational support. You need to give them information, explain, psychoeducate, all those things. Help them with the positive activities, okay? And some sort of social support. Find out what is there locally. And then the respite care, I feel, is very important. If there is no scope, no choice for the principal caregiver to go out, have some time for themselves, it becomes very difficult. So please try to see that the care is shared by the other family members timely, so that the person is relieved from their caring responsibility to do something else for their own. Okay, simple thing is exercise, to go out, to go to a temple, or to do religious activities. So that's pretty important. It's not happening. Examples are many. Like from here, there are adult daycare, adult day services, respite services, in-home care. Somebody can come and take care when people go out, like Natalie was having. Overnight respite, elderly people can be taken to overnight care home or nursing home to stay there, and then they come back when the family comes back from holiday or a family festival. Or there may be a care home facility, temporary or long term, they can go there. So that respite care is pretty important. I know it is not there. I think that's the reason I'm bringing it up, so that maybe individual practitioner level we may not be able to do, but as at different levels it can be done. Suggestion for support in India, improving psychogeriatric care. This is an interesting article written by Saji from Kerala. I think when he was writing in 2004, he suggested and actually thought about the carers. So it is there already in our mindset. While developing the psychogeriatric care in India, while we need to develop like community health workers and outreach programs, psychogeriatric clinics, support to the carers are also important, and it has been there in the literature. Now let's go to some group interventions, specific about interventions. This is done in Nimans. So they did some group intervention, which has three kind of models. Like session 1 would be psychoeducation. Session 2, a psychosocial management of the aged person, what can be done. And session 3 would be welfare measures available for the aged in India. So that will be sort of discussed or informed to the caregivers. Now online training has come up pretty big way. I know the reach is not much in the elderly population or their caregivers, but it is growing. And now more and more interventions are being done online. So I think we should embrace this and take it sort of further. There are a lot of studies now, even from India. Now, following 3 focus group discussions with family caregivers in dementia, these are some sort of expectations Borua and others have put together. That expectations are information about identification and management of dementia, which is easy, which can be given. To support caregivers' well-being, to use simple language, cultural relevance, and interactive design. Okay. Now, app can be developed in different local languages, so those things, and it can be done at individual practitioners level to departmental level to college level, institutional level. What are the challenges? Lack of time, difficult in accessing internet, which is, I think, an issue maybe in rural India. And those who do not, those who cannot afford, I think it is becoming more and more common. But it is not gone like 30-40% in that age group, it is still less. There is a lack of awareness about the portal and difficulty in reaching the rural population. Already they have sort of mentioned. Now, some more information about internet-based intervention supporting family caregivers of people with dementia. It's a systematic review in 40 studies, and they felt the interventions most in these 40 studies focused on contact with health and social care providers. I think health providers, we are kind of all there. Social care providers in India, I struggle to find. Obviously you can help, in the discussion that what is there actually in your local that we can put it in. Peer interactions, suppose one caregiver, a dementia caregiver with another dementia caregiver, so they can have that, and we can facilitate that. Provision of information, decision support, and psychological support. These studies actually suggested that if you give some intervention, it may be beneficial to the family caregiver. So some intervention will definitely be helpful. Particular benefit came from psychological support provided online, if you can give that. And if you can actually, the information can be specifically tailored to the person's need, not a general write-up, If you can, one can understand what this caregiver is struggling with, and if we can tailor the information to that particular person's need, it will be helpful. Peer support again, and online contact with a professional. I think this has grown in recent year with the psychiatrists and other professionals. So that's a good thing, and that has been helpful. Information on intervention of family caregivers of dementia from Asia. This is around 30 studies done in Asia, but is basically most of them have been done in Hong Kong, China, or Taiwan. So only 4 studies, 13% were done in other countries. So, but then they felt multi-component intervention, not just one. There may be different things, different kind of intervention will be helpful. And some specific intervention which we can always suggest. There was a study which is home-based physical exercise program. Now, how much we can utilize that, but we can actually culturally adapt it. But they have found it, if the caregivers do that, that will be helpful. There are some models in Canada where they actually have caregiver-directed intervention for dementia, though actually they have patient-directed and caregiver-directed intervention. So we can actually think in those lines. Just wanted to mention a study here, which has actually come up as a negative thing. So I thought, oh, okay, we need to actually share negative findings as well. They tried to do a computerized intervention and supporting the family caregivers, having some contact up with them in the NHS, around 9 contacts in 6 months, but then to see whether the challenging behavior and dementia is changing. But after all these interventions, it did not. Okay, so they actually found out there is a gap. With whatever we do, it may be very difficult to change the challenging behavior, and it may be difficult for the family members as well. So negative, what doesn't help also, we need to sort of share. There is an interesting study now is in COVID in Chennai. In the SCARF actually, they gave some support to the caregivers. Now the caregivers suggested what will be helpful: video consultation, telephone-based support, clinic-based in-person visit to meet their needs, and wanted more services post-pandemic. Author obviously suggested multi-layered approach, systemic changes, which we are doing. So there has been some studies during COVID supporting family caregivers for elderly as well. Now, coming to this, is there any policy law or acts in India which is actually helpful for the caregivers or actually dedicated to caregivers? Sorry, I didn't find any. I'm not an expert, so maybe we can share this area. I know there are a lot of laws protecting the rights of the elderly and how now sons and daughters have to support their elderly parents. That's good. But I think there should be some policy somewhere supporting the caregivers as well. So in different ways, we can discuss that. Now, next time you see an elderly patient, I'm coming close to my discussions, think family. Think family, just not the patient. Think family, the family who is the caregiver. What additional support you can provide to her, his or her family caregiver? Who is identify the primary one? What is their distress? What can be done? Can we arrange some help? What are the support system in the local that you can actually suggest or guide them to seek help from? Because not that everything we can do as clinicians, mostly having clinic-based practices. It will be difficult. Now, coming to my close, there's some take-home messages. While taking care of your elderly patients, take care of their caregivers in the family as well. Inquire about the well-being, identify who is the primary caregiver, and check how they can be helped. Asking very key questions, we can easily find out whether they're stressed, depressed, having anxiety. It will not take long. And they can definitely be helped for these things. Just acknowledging that this is stressful will melt away a lot of things. Psychiatrists have a greater role as most of the caregivers have stress symptoms, burnout, depressions. I mean, we are still help people, those who are taking care of cancers, of elderly patients. Culturally relevant coping, relaxation techniques add value to their work. Time out, like respite, and local self-help groups will be helpful. Carers group can be set up. That can be a face-to-face or online, and it can be done at departmental levels or individual practitioner level as well. A lot of work on dementia carers, but not much on depression, as I mentioned, and other psychiatric problems in old age. So if you are all interested in writing, researching, then do research what is happening with the caregivers of depression, elderly people with depression, and they are 20 to 40% of them could be depressed. If you take a kind of adjustment figure, suppose 20%, 1 in 5 people in the community are depressed. How many of them would be visiting a psychiatrist? Very less, 5% maybe. So if we pick up those persons depressed, do ask their caregivers how they are coping. Now, there is a need to consider care issues related to multimorbidity. If this person has depression or dementia, what are the other things that is troubling him, like physical problems, which is so very common in old age. Research need on the interventions and their efficacy in decreasing carers' burden and improving their quality of life. There is a research need is there. We need to see what intervention we are giving, whether they are really effective, whether they are actually bringing down the depression and the stress in the caregivers. So thanks for your attention. Thanks for giving me a chance to talk in this August gathering, and please share your views now.
Thank you, sir.
Thank you, Dr. Kar. I hope I'm being heard.
Yes, yes. Thank you.
For a very exhaustive, informative account of family caregiving, which you narrated by case vignettes. It was indeed a good one, and I'm sure that many of us would be benefiting by this. Before participants ask questions, I would like to say that issue of caregiving is very sensitive, emotional, and at times very frightening. If you think for yourself itself that one day I'll turn elderly, and God not willing, if I develop a problem, who will take care of me? That's an important issue. In practice of psychogeriatrics, I've been facing this issue, and many times banking on family itself, where people are occupied with their job, with the other kind of engagements, they are not able to care for the elderly, and the elderly are neglected like anything. Besides family, the other kind of caregivers who can be hired consists of both trained and untrained. But they just work like a, say, outside people, just doing little bit without providing any kind of emotional, any kind of other support. Many elderly, what we see that these people are subjected to lots of neglect in the house. Even the close members of the family, they do not bother. We had started many programs, family training. Our social workers used to visit some of the families to guide them. Even then, the perfect kind of care what we expect is not there. But at the same time, there are some families who are so devoted to their elderly that you do not need to explain anything to them. They understand the need of the elderly person, and accordingly they tailor the care requirements. A variety of situations exist, and the worst part of this caregiving is the burden on caregivers. We have seen many people getting psychologically disturbed, getting physically sick while engaging themselves in the care of the elderly. For those particularly who do not have at least something in their cognition, and they are not able to take care of anything, even any activity of their living. So such situations are there. We need to have some kind of an organized effort to create a kind of caregivers in the country who can take care of the elderly. How this can be done is to be thought over in such meetings, because today the requirement is there, and with the population of elderly increasing in the country and the psychogeriatric patients as well, we will need lots of caregivers to take care of the elderly population. With these closing remarks, I hand over the mic to moderator to invite questions from the audience.
Thank you, sir.
Thank you, sir. तुम start करो. करो, करो.
Sir, Nirvana sir, thank you so much. I think your first question was a wake-up call. Whether I will be in a nursing home or not, so I'm still thinking on that. कि मेरा क्या होगा? So I think this is a very
that's a very emotional situation.
Yeah, because
we all are getting old.
Yes, sir.
And one, we should think who will take care of us if something bad happens.
Yeah, so, and sir, in last hour, I have been through my memories with my late parents. So how I pass their last phases with myself. So my question is, most of the things now turn up to be cost related. Whatever we know, बहुत सारा कुछ करने को है. We can do many things are there, but again the cost is an impediment. So sir, what we can do at our level, how do we take this cost factor, make things cost effective? Now the joint family system, we are moving to more of nuclear family, single person staying. So इस केयर को कॉस्ट इफेक्टिव हम इंडियन मॉडल में कैसे बना सकते हैं? As Tiwari sir was saying कि people are trying, but there is such a huge gap that cannot be covered. So क्या हमको अपने में आज से इन्वेस्ट करना चाहिए? Should I start investing in some people who will become my carer later on? कैसा मॉडल क्या हो सकता है सर? नील माधव सर.
That's very pertinent, very scientific and very relevant question.
जी सर, thank you sir.
We can prevent the need of caregiving by a healthy lifestyle, by exercise, and it is a call to all elderly who are going to be really elderly that to bring changes in their lifestyle so that they remain free from illnesses, do not require any kind of caregiving, and they have a kind of graceful death. My son, who has turned out to be now a motivational speaker, remaining healthy for a graceful death is very important. So that's a kind of message the family should encourage elderly to indulge into such lifestyle which is good for their health. And that is one way to, one model to
I think you are muted, Professor Tiwari. Yeah.
we will also have to think of organized training for members of the family, and in case a need arises, what should be done for the activities of daily living, what should be done for the cognition, what should be done for the behavioral problems, and how to recognize minor, say, issues or kind of situations, medical situations and psychological situations, which can be managed and in what way it can be managed. These all issues should be addressed to either through training to members of the family or by any other means. And we will have to prepare ourselves to do that. We have been in the Department of Geriatric Mental Health carrying out a family training program, because the other kind of caregivers, either you take the trained one. There is an agency in Lucknow which trains these caregivers and provides to the families. But it's always a complaint. They do not work with the kind of emotions the elderly require. And in that respect, the members of the family, whosoever takes care, has at least some emotional attachment to the person. So we have been carrying out that kind of training program for the members of the family where the care is needed, and that has been quite successful. I believe this kind of activity, at least for those elderly people who come to our attention, their families should be trained how to provide care to the elderly in situations of activities of daily living, in situations of any kind of physical problem, in situations of any kind of emergent psychiatric symptom like that.
Thank you so much, sir. Nilmata sir, your comments on the topic.
Yeah, my point in this is, yeah, one needs to actually invest. Cost becoming an issue. Here, few years back, people used to sell their house to go into care homes, because it is very costly. In India, what is happening? People stay on in their own homes because of cost factor or whatever factor, and there is problem is there. Many times neglect is there from the family members, emotional abuse, and all those things are there. Investing in your old age thing is kind of a need, but it cannot be just one group of people doing it, because if you need to have trained carers to come and do it. It should be need based. As much as you need, you should be having that. It doesn't mean that when you are still functional, you need to move to a old age home or care. The problem is, if your family members are not there or they cannot care, at that time one has to, and if you need the care at a level of activities of daily living, the trained carers either coming home or you are in a place where they can take care of you. So that is kind of thing will happen, and that will need cost. And I think, I do not know whether that is there. For example, caregivers should be recognized. There should be a carer allowance. People should be supported by the government through something in some way. There should be thinking around it. That is the key thing. Individually speaking, it is emotionally very disturbing. Suppose most people may have a graceful sudden death and fine, but they can't plan it, isn't it? Some people unfortunately will go into difficulties that they need care. Even for months or years of care will be very costly to actually afford. Even for those who have, but I think most people, when we do not have, I think in the economic strata, when there are a lot of people are actually in the lower or middle, it will be very difficult to actually afford those things.
Sir,
And
should
no
I start
insurance
making
is
a
also-
small fund? Should I
That's very
start
very
suggesting
true.
people कि थोड़ा सा fund बनाइए जिसमें आप हर महीने डालिए, and then in your old age that will
That's a good idea.
That's
a
what
good
everybody
idea.
is doing in India, no? Sir, one interesting question.
No,
You-
that
you-
cost factor remains everywhere in the world.
Yeah, true, very true.
In US, I have seen such nursing homes managed like a 5 to 7 star hotel. But
Absolutely.
the day elderly fund finishes, they are put to the country hospital, the government hospital, where there is no government nursing homes, where is not much care is there. So cost factor is always there, and
Everywhere. Yeah.
yeah, it's everywhere in the world.
Dr. Kar,
Sir.
there's small addition. I think this question was raised before about legislation and policy. What has happened is, I'll tell you a very small story, then it becomes easy for us to understand.
That will be nice.
It was an excellent presentation by you, and I was so fascinated by the stark contrast that we have in these two countries. That's the important part.
Thank you.
About this law, what has happened is recently there was a lot of articles in the newspaper saying that the local government here, Assam government, had been seeing a lot of people who are on the streets being neglected or thrown out by the relatives. So what has happened is there is a huge group of people. They created a platform where they're saying that negligence by the relatives will have be strongly discouraged by the government. So a policy was made, a law provision was made. What has happened is, because of that, the government servants, it was covered. Because if you're a government servant and if you're found to be neglecting somebody, then the punitive measures will be taken by the government in taking out a share of your income and putting it in the name of your, say, whatever wards. Now the issue was, you take away the money, give it to whom? You need the agency who will at least execute that part of the work. So what has happened is, some people have developed, those NGO setups were developed. In NGO setup, you give them the money, government gives them a share of it, then they run a old age home. Now the biggest problem issue was, this old age home was not specific to any specific disability. So what has happened is, they have taken the old people in. Now we have a group of young people who are looking after them, who are moderately, say, trained. I won't call them properly trained. They were introduced and inducted to taking care of old people in the age-old homes. So what happened is after 10 to 15 years of time, these people already burn out. Burn out in the sense that the eagerness, the will, the exuberance that gets lost. So ultimately they leave the place. So you keep on having a new batch of people who are not trained, there's no standardization. So that was a major issue here. That is one part. Second part, which everybody has been telling, is about setting up a nursing home or a care center for the elderly. Will it take away the burden from the caregivers? Like you have said, in the West, they have, it's not that innately they want to get relief from the taking care of their wards. It's not like that. Everybody wants to do it, but are forced, compelled to say, compelled by the situation and circumstances, they cannot do it. They get burnt out. So what has happened is, we have care homes, we have a place where government subsidizes to a great extent, but the reason that the voice of those people, the caregivers, is not heard much. Because of his policy was, I think, a bit, it requires to be more fine-tuned. I think that was a great message which has come across from you.
Thank you.
That is one addition I have in mind.
Sir, in continuation to with what Dr. Deori was telling, Dr. Nilmadhav Kar told that he didn't find any legislations regarding care of the elderly. So I have heard of a scheme where the government came out with a reverse mortgage scheme, sir, where people were actually waiting for their parents to die so that they can take away the property. And many times I've heard people not taking care of the parents because they wanted the property. So the government came out with the reverse mortgage policy. And I think that's not a bad policy, where if somebody has one property and they have no additional source of income, they can avail 80% of the property value in lump sum or maybe in parts. And either if they can't repay the loan and if they die at the death of the guardians, if the son or the daughter wants the property, they have to take care of the loan and then get the property, or the bank mortgages the property. So that was not a bad scheme by the government for people who only had one property, who had no place to live, and that was a nice. Sir, were you looking at specific legislations, Dr. Kar, when we are telling that what are the legislations that should be incorporated? Maybe with Dr. Deori and maybe Dr. Tufanpati will be, there'll be responsible people in the society, in the psychiatric society. Are you thinking of specific legislation that might help the elderly? So if you can talk about certain things, we might be able to carry it forward, sir.
Yeah, it is something like carers should be, there should be somewhere besides finances, there should be some sort of social recognition. There should be given some feedbacks, starting with that. There can be given some financial allowances, coming to money. And then if they should be recognized, yes, this person is actually responsible for the care of this particular elderly with dementia or depression or whatever, or in anything. So once they are identified, they should be supported, and here there is carer allowances and all that. So that can be given. I don't know, it's actually a very big thing, isn't it? Anything you think in India, it's huge number of population, and government has to really think through it. Coming to the say support from the NGOs, in India there are a lot of NGOs. I think that's basically because we don't have a very good social services there. Government run social services is pretty important, and if they will be there, and they should be, then what happens in NGOs or the organizations, NGO or the companies which provide these carers, whether they are doing good job, whether they are actually quality, their quality should be controlled, and our psychiatrists should be in that quality team. Here there is a quality commission. I'm giving an example. So they will go, they're so powerful, they will see if these elderly in this care home or the care, those who are providing the care are not up to standard, they can stop their services straight away. Okay. So the organizations, companies can, stop functioning. The care company, anywhere if they're providing care. We don't have that there. We need to have a very strong, independent, kind of commission, where psychiatrists should be there as a team member, because we are the ones who can see that. Because what care we are getting for our money, that is also another area which needs to be looked into, because it is the carers in many parts, family members. We already heard about neglect, emotional abuse, not good quality care, and all those things are already there. So we need to look into those things. There can be another thing about tax rebates for the caregivers. If they are earning or paying too much of tasks, so you can encourage them by tax rebate, at least those who are high pay, higher end of the economic strata. But for lower end, they should be provided with some sort of support. At least recognition will help.
Yeah.
Thank
And
you,
sir,
sir.
in addition to the financial investment, I think investing in the family values, when the let me relate this with the elderly abuse issue. What I have observed, there is the subtle abuse. सर कि वो आए और बोले कि सर ये तो इतना इन्होंने परेशान कर दिया. The tone in which the caregiver is describing the behavior gives you an hint कि the caregiver is already burnt out, he is already frustrated, and probably some people admit also कि सर कहते कहते मैं इनको इतना बुरी तरीके से बोल जाता हूँ, then I repent later on. So elderly abuse can be very subtle, too obvious. So I think investing in family values, कि उसको अगर ऐसा बोलें कि जो आप अपने पिताजी के साथ करेंगे या अपने पेरेंट्स के साथ करेंगे, जब आप बूढ़े होंगे तो आपके बच्चे वही सीख रहे हैं और वो करेंगे. So this is my standard response to this. So sir, इस series में what is your comment on this stream?
As you mentioned, it is a very sensitive issue. Many times we have seen elderly people do not come and tell about the abuse they get or emotional neglect they get, and it needs lot of frustration to take it out every day. So one has to be very sensitive to bring that out, and it is a very sensitive issue to even communicate to the family members. But when it is there, it is the clinicians who has to identify and raise the voice that this should not be happening, because we are not only taking care of, but at the same time, if you see, we have to see the situation and try to support so that this prevalence of abuse comes down gradually. And suppose you imagine if somebody is caregiver is frustrated, and doesn't know how to handle a challenging behavior, or the person is not improving, there is nothing for that person with the caregiver for to go out or have a choice to live his or her own life, or even have some time to himself or herself. The frustration actually leads to their behavior changes, and that becomes abusive, isn't it? So I think if they are properly supported, a lot of these things may come down. And that support can be even, from emotional support to psychological support to there has been cognitive therapies and all that. Basically supportive therapies, and to the extent obviously of, if somebody needs a financial support to take care or respite care, those things should be brought in so that the abuse component will come down.
If I can respond to Dr. Alim's question.
Yes, please.
Sure, sir.
Investing in family is an important aspect. And we doctors, psychiatrists, physicians, surgeons, whosoever is treating an elderly people with some kind of a psychiatric or a physical disability should try to tell the members of the family the subsequent problems which may arise and how to handle them. I think if this individual approach is taken care of by the treating psychiatrists, treating physicians, treating surgeons, whatever, then a lot more work of caregiving can be done by this kind of training and making members of the family aware that these kind of problems may arise. That's a very successful model which we have been doing, and still we encourage other colleagues also to practice that kind of situation. Whenever a crisis situation arises in which a member of the family who is giving care breaks down, or he you can say abuses the elderly person, either physically or verbally, whatever, that we should tell them that these can be the situations which you need to understand rather than bursting on the elderly person. And I believe if this can be done by us while treating an elderly person with any kind of disability, a lot more will be achieved. There cannot be any such agency, cannot be any such government order or law which can carry out all these programs. And we will have to take the responsibility of treating and training these people together. Thank you.
So, छोटा सा addition, if you don't mind, just a small addition. Can you hear me?
Yes,
Okay.
sir.
Yes, you're audible.
Achha, what has happened is, I'll give you a small example. How, I mean, this is a little digression, but in a way, it's relevant. What has happened is, supposing we have a family member who's a caretaker and who's, say, having a lot of stresses and issues. Yes, we address that issue. We address the family caregiver. That's fine. Sometimes it so happens that you don't have a close family member who's a caregiver. The primary caregiver is a professional caregiver who has set up an NGO setup or whatever it is. What has happened is, supposing I want to set up an NGO setup for giving care to elderly who has, say, some issues in psychiatric issues, then what happens is, I go to the government, I say, I am going to do this, I set up a place, and I built up a small space. That is exactly what has happened. I will not name the NGO, but those type of things are happening. When they start the NGO, when we talk with the government, supposing we have to negotiate with the NGO, then we say that, okay, if you want to do this, you know the minimum care that will be required will be this many people, 24/7 care, professional care, trained care, and emergency care. So the person comes up with an arithmetic. He does an arithmetic and says, to be viable to keep all these people, I will have to have 100 people, 100 bedded capacity in this place. So the government said, okay, you start with that, we will give you 200 rupees per day per person for 100 people. So they get a setup. Now what happens is, it is basically a finance. That is where the NGO is difficult. I mean, what the NGO does is, he has a 100 bedded setup, he gets a say government help or legacy for 100 people. His interest is not in keeping 100 people. His interest in keeping lesser people. So now what happens is, they keep saying, quoting different type of things, because there is an exit policy through which it goes to different agencies. From the care home, they will go to hospital, they will go to somewhere else. So what happens is, he will try to divert all of them to different places, and on a given time, there will be only 50 people in that particular setup. Now what happens is, like Professor Kaur has said, if the government agency goes there and says that you have this problem, why are you keeping 50 people? When your capacity is 100, and we see a lot of people who are in need of this, what happens is, this particular person will say that this is something which is only for today's arithmetic. Tomorrow the arithmetic will change. So we need people that monitoring of this type of setups will require a different type of thinking. With only telling them, giving them psychotherapy, telling them, initiating them to moral part of it, initiating them to say spiritual part of it, those caregivers who are professional caregivers, I think it may not be enough. We may need to do a little bit of thinking in strategizing how we are going to set up and help those people in NGO sector or whatever. The governmental sector, it's not that easy because it's a huge, the mechanism is something which fails because of the numbers. Numbers are overwhelming. It will come in some lakhs. So that is almost impossibility. So when these private players pitch in, this is a gap which I think all of us will need to delve into, think about it, and look for a solution. If we don't do it, then what will happen is this will collapse. It will come out suddenly with a spark, things can come up, but hoga nahi, because that whole thing is based on something else, which individually attending to their calling up their spiritual and moral part doesn't help. That's my guess. I mean, I have experts who have done more work than me in this area. So I'll love to hear from them.
Dr. Kar, sir, there is an interesting question, and that is what we come across many times. One of the primary causes of caregiver burden I see in India and in our setup is if somebody has 4 kids or children who have grown up, one children is looking after the parent and rest all are neglecting. And somebody who is kind, somebody who is compassionate, even if he or she does not have a lot of financial, strength or manpower, is looking after the parents. And somewhere there is guilt, somewhere the spouse is putting all the pressure that why should we only work? And that's a very pertinent thing. Like in UK, somebody can go out, but once in India, if you have a parent who is bedridden or who is having some issues, there's nobody to, if you don't have an immediate family, we don't have places where we can keep them. There is no holidays, there are no, going out. Even we see that when we have a ADHD child or somebody with autism or somebody with a cerebral palsy. So what do we do when such things come, when some caregiver comes and he or she is depressed, agitated? How do we handle such things?
Yeah, you brought in a very interesting dynamic what is happening in our joint family system. Even if they're joint, people are now actually living separately and they are not sharing their responsibility, taking care of the elderly parents. So you have seen this beautiful movie Bhagwan or something, Amitabh Bachchan's, where now parents are being split as well. Nobody wants to take care. So this also happens in extreme. Very difficult to find a solution for that. Many times, some of the sons and daughters, they do not take care. And expecting them to take care is sometimes pretty difficult. There is no easy answer to these things, but I think what should go in some way in the bringing in family values, I think Alim was mentioning that highlighting that you need to have some sort of sharing rather than shifting parents to hither and thither. They should come and relieve the other caregiver for certain days and time. It can be planned, it can happen, but a lot of people do not do. Their interest is not there. And when somebody is not interested, you can't force them to take care of a person. Then it will lead to more, neglect, abuse, emotional abuse, and those things. So we need to find in a big family who are interested and how they can share the burden. And when they coming to share the burden, it should be very logical, very methodical, time and date and clear wise that somebody can actually relieve the other person who is taking care. But I see that it doesn't happen. It is the person who has no choice, who is the primary caregiver, continues to do that, becomes frustrated and goes on, live a life which is not very comfortable for him or her. So, and who suffers? Both the caregiver and the cared for persons, both elderly and the caregiver, they suffer. So I think we need to have a really, look into this problem that is growing. You'll be surprised. There have been studies now where a primary caregiver may be depressed as well, and somebody who is not able to take care and wishes to take care also feeling depressed. But many times the kind of situation you are describing, people are not interested. Other brothers and sisters are not interested to take care of the families, which is very common. And this is a negative side of our joint family system, where the expectations are there, but it is not delivered. Nobody is really contributing to that. This is a dynamic which is less studied. We always praise for our joint family system, but many times these dynamics are also very stressful inside that.
Yes, sir, a short and sweet question. What are the positives of staying in an old age home?
Was it positive? Oh, that's really good that you asked that. You know, you'll have a lot of peer. You'll have a lot of time to talk to. If you have faculties are okay, you can talk and make merry and enjoy. You can have new friends and enjoy a movie together, and you can joke, laugh, do things together, and you know, so sometimes it is pretty good. And if there are people who can help you facilitate those kind of group discussions, you can have you know, games and all that, which being at home, stuck at home, you do not get. So before actually transitioning to a old age home, there should be opportunity for going to a, you know, daycare center and all that. So where you can get all these things, but you come back home in the evening to be with your, you know, grandchildren or children. So yeah, there is some positive point in being in old age home. It's not, suppose you are actually, somebody is being abused at home, okay? Emotional, physical, it is very true. If you see Helpage India's report recently, last year or year before, it's very pathetic. Bhubaneswar was at the top of the list in Indian cities. I was shocked. I was really shocked. But the problem is, it is happening in our, if somebody is that physically sort of abused, I think that they are the people who can go, and the family members need help, you know, and they can be helped, and maybe if things are better, they can come back to their home. But there can be reasons why people can go to a old age home. And we have actually done some studies, like in old age home, their quality, they're not very good. They're not very good. So I think that's the reason I was stressing that there should be an independent group of people. Maybe every city should have that kind of, and they can go and assess and say whether this service should continue or not continue. You know, then people should at least have some sort of, you know, sense that, you know, this care home is good, or okay, I can. So for example, a lot of people who live away from their parents, they're wondering, my parents, how can they will be in a better place? They can send them to a old age home if it is good quality. Like Professor Tiwari was saying, in USA here, there are high-end old age homes where we cannot afford, you know. The monthly cost is more than a consultant salary here. Okay, so that is, you know, where they can afford actually. That's a different thing. We are talking about masses, basically the middle economic strata, which will be pretty difficult to get a good, but we should prepare for that. We should have good quality care homes where not numbers, but quality should matter. And there should be somebody who can go and check those qualities being maintained. I think it needs work from professionals, including psychiatrists, local people, and the government, you know. So all three, I think Indian Psychiatric Society is the best place, you know, to kind of think about it and take it something further. I mean, we are discussing, I think, see, so much of interest in these areas that I think we should sit together, and psychiatrists should be there in these committees. You know, they are the ones who will pick up, you know. You can see and, you know, guess that this, whether there is stress, there is difficulty or not, which a lot of other people may not, you know, they may have come up with different things, but we need to be there. And I think that is as a kind of shared goal for all of us. Thank you.
So thank you, sir. Dr. Pranab Mahapatra from Bhubaneswar, he has done 2 studies on some of the aspects we are talking about. So he just wanted to share a very small point. Yeah, Dr. Pranab.
Yes, we recently conducted 2 studies, one on elderly couples, how they managed through the epidemics, through the pandemic with multiple illnesses, and second regarding dementia care during pandemic. 2-3 findings that are very striking. First is that there's a scope for a family physicians. Many of these patients, they wanted at least someone should visit them once a month or sometime because they're staying alone with no one to take care of them. Most of them are elderly. Second thing they told me was that while visiting hospitals, they have to stand in the same queue as others. There's no special facilities, or sometimes they have incontinence, they can't stand in a queue, but they have to carry on with their procedures throughout the whole day. And third thing that I would like to say is that when taking elderly care of the elderly, most of the children, they are elderly themselves. Many of them are crossed across 60 and taking care of a 80, 85-year-old person, father or parent. So these are the few things that I would like to see that they needs to address in the future, care of this elderly population. That's all from my comments.
Thank you, Pranab.
Thank
Thank
you.
you.
Thank you. Alim,
Sir, Kar sir, one slightly awkward question. What about the sexual needs of elderly if they are single and staying in a home, staying in a nursing old age home or their own home? So, what is actually happening there? What is your comment on this?
Yeah, I think the needs continue. I mean, how they address that. Many people are here, suppose they have their partners and all that, that's kind of fine. But if they don't have
Suppose in an
partners,
old age home, what happens? Are there some issues that are arising?
here in the old age home, they actually take really old, very old at the kind of end of their, I haven't heard anything. But as you mentioned, I would just remember that there was a BBC communication recently during COVID. Like I think they do pretty well in communicating that, saying during COVID, this is like you are the best partner for yourself for sexual activities. Then if you have a partner, then you should go this way, not with face to face. Face can be separate. So they can be, and sex education is there from the very, school here very regularly. But in old age homes, I haven't heard anything, because they're very sort of, mostly they are frail and all that. But I do not know. This is another area maybe we can look into that. I haven't heard anything or not kind of research recently on that.
Yes, sir, there was a question on cognitive stimulation therapy. Any views on that? Cognitive stimulation therapy, someone mentioned in the chat box. That they are.
Yeah, I think, is it for the caregivers or the
For the patient,
patients? A dementia patient, yeah, a lot of, I think, therapies are being talked about, tried and all that. And this is sort of one of them. I think there are various, therapies, how to stimulate or remediate or rekindle the cognitive functions, or how to channelize them to have more meaningful, life. Suppose one particular faculty is less or cognitive function is less, maybe one can, for example, in music, in creativity, in painting, a lot of other things that can be done. But yeah, that's more for patients.
Okay. Amit, should we hand over?
yeah. One last question, maybe Dr. Sally has asked. I'll just ask. So, how to hold a geriatric patient in a therapy process? In India, where the physical health is usually ignored in elderly patients, the mental health is often neglected. Which is a better mode of therapy for caregiver burden? Caregivers group, family therapy, or individual psychotherapy? So, this will be last question. Then we'll close it.
I think, as I mentioned, one solution will not fit for all situations. So it's good that the person who has asked has actually narrated this. So, but what can be done at individual practice level? One can have, as I was mentioning, a peer group support. They can register if you have a few dementia patients, their caregivers actually can have a group, and your as an individual practitioner, you can facilitate that. So that is one thing. You can do a group therapy, which is very common, and as soon as that group settles down, they can be helpful or therapeutically meaningful to each other. So you don't, as a practitioner, have to spend more time on that. Then they can be support group for themselves. But some people who have clinical depression or anxiety or stress symptoms, they may need individual therapy, supportive cognitive therapy, and those kind of things will be helpful. So it will be like you have to assess case by case and find out which one will be better. But at departmental level and individual practitioner level, I would suggest that, set up this peer group or group therapies whenever possible. That will not only help you or your, patient clientele, but their family members as well.
Thank you, sir. Thank you so much. So over to the chairpersons for your concluding remarks, sir.
Thanks, everybody. It was a wonderful session by Dr. Kaur. A very elaborate presentation about caregiving. At times, it appeared that the old age homes, the nursing homes, and the home care, they are being confused in several aspects. But whatever has emerged out, that I believe will guide us a lot. The last three questions, one by Dr. Aleem about sexual needs of the elderly, who should be trained, and the answer to these questions, for example, the elderly, sexual needs of the elderly, it is not very much, even if they have a partner there. With the decline, with the increasing age, the sexual desires and everything decreases. That's very obvious. But sometimes if the same person develops a cognitive deficit, he might abnormally indulge into sexual activity. That situation has to be tackled that way. As far as training home, if somebody is giving care to the person and he's exclusively involved in the training, in the care of the elderly person, then he should be trained first along with other members of the family to provide him support, to provide support to the caregiver. And caregiver should be trained to manage different situations in the case of sick elderly, whatever, whenever they arise. We need some kind of model where those elderlies who are now left in their houses alone, the children have moved out in search of job and all that, how they can be approached, they can be managed. Once in Lucknow, I thought of providing elderly friends from the same community. Some people might go and visit them, but then the issue of security arose there, and I could not do that. But we will have to think, the government will have to think, the NGOs will have to think of developing something like that, that those elderly who are left alone in the houses, how they can be visited, how they can be cared, how they can be given some kind of emotional support. So many issues are there, and in different cultures, in different economic strata, in different situations, we will have different kind of models. Thank you all once again for such a lively and such an informative discussion. Thanks a lot.
Thank you, sir.
I am very happy now that I made my introduction very short because we had enough time for discussion. Thank you very much.
Dr. Tufan, sir.
Okay, thank you. I shall make some observations. Observation number one, everyone will be old if he does not die young. This is fact number one. So the state, the elderly are now in India as well as all over the world. It's not the granny battering is not only limited to India. The report of the quoted by Nilmara Bhubaneswar is at the top. It's not exclusive to Indian context. There has been a nice report in 2007. I made a presentation a few weeks ago where it is mentioned that above age 70, the rate of abuse increased around 20%. And it further tells that the perpetrators are mostly the family members.
Very true.
It is an observation of NICE 2007. So it is present everywhere. But where we lack, it is the value system that we developed. Had we developed that 2, 3, 4 decades ago, maybe position of the elderly would have been better now. I shall quote another thing by telling you about the budgeting. You go for an average family budget in India. House, gym, bills, education, gym means it is a good family. Everything gone, miscellaneous is 2. Out of that miscellaneous 2%, a fraction go for the elderly. And this is reflected at every level, at the level of the state, at the level of the division, people are in need of that. And we are going to send our children outside because that is the parameter of being settled. So this attitude is most important. And as Dr. Tiwari told, we must develop a lifestyle, promote that in the families. We should increase awareness so that we need less of, become less dependent when we are at the fag end of the life. These are one of the important, and another is the insurgence of ageism. I don't remember exactly. There had been a study in a medical college, maybe John Hopkins University, where the interns were studied whom they will prefer to choose to treat emergently. A girl of 15 years old or a aged lady of 85 years having similarly severe condition. Ageism indicated that 85% after that they will be treating the girl first. That means when you are delivering the services, you are also discriminating the aged at the institutional level. And the plan support may be feasible if you have got enough manpower. And fund is that we have to have the budget from the beginning. And that must be made in the spirit of the family pattern, all the family members. We don't have time to discuss about the joint family system. I believe it survives in India to some degree, though it is in a phase of transition. We are having different types of joint families with different conditions, different aims, and different objects. And the only act for the prevention of cruelty on senior citizens and parents that is not being implemented properly, because that needs the elderly to demand it. So this is the condition. With these few observations, I would like to thank profusely Dr. Nilmadhavkar for being with us and allowing us to have a reunion, and Dr. Tiwari, the father of geriatric psychiatry in India, to have graced the occasion, and my dear friend Deori, who is the director of in Tezpur Institute, to have spared his time today evening. And again, best wishes for Makar Sankranti, etc., 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 to everybody.
Amrit.
Thank you.
Sir. Thank you, sir. Sir, I'll do the formal thank you on behalf of the IPS Odisha State Branch, sir. First of all, I would like to thank our own family member, Dr. Nilmadhavkar, one of the most gentlest man you will meet, one of the most knowledgeable man you will meet. You know, is just like elder brother. Whenever you go, he talks to you with a smile, ever affable. Thank you so much for sir for joining us from all the way from UK. We have never gone there. Alim has seen it in Google, but today we met you, sir. Thank you so much. Thank you, Dr. Tiwari, sir. You think of geriatric psychiatry, the first name comes to you is Dr. Tiwari. So thank you for joining us, being so active. Thank you, Dr. Deori, all the way from Tezpur, sir. We have met so many times, and it was wonderful hearing from you. I'd also take the opportunity to thank Dr. Tufan Pati I hope he reaches where he has been aiming to reach, and maybe in a couple. Thank you to all our, even though today will festival day, east, west, north, south, central, everywhere there are festivals.
Right.
We didn't
Today
have
is a
too bad
celebration.
days. We had more than 170.
Today is a celebration day for Thirst Music.
Come. Yeah, and today is Silver Jubilee.
Silver Jubilee.
We have 25. When we thought about it, we thought maybe we'll do 8 or 10, but we have reached 25. And the next session is also on narrative therapy on child sexual abuse by Dr. Shekhar Seshadri. So we have had brilliant people. Our audience have been superlative. The questions that come to us, and it is the most interactive program you see. In no program we have 1 hour 10 minutes, 1 hour 20 minutes of question answers. So thank you, our viewers. We have a very dedicated, very loyal, and a wonderful bench of friends who are with us every day. Thank you, Torin. Thank you, Pavan. Thank you, Sharda, Sazia, and Rucha. They've always been with there. Thank you, IPS OSB, our President, Secretary, and our CME Chairperson. And I would like to thank Alim also, who tries to always take the spotlight away from the speaker and the chairperson to himself. Thank you so much. Have a happy Makar Sankranti. Thank you again, sir. Tiwari sir, Deori sir, Nilmadhav sir, and Tufan sir. Good night.
Thank you.
Good
Amrit.
night.
We'll meet again next Thursday.
Good night, everybody.
Same time.
Thank you. Thanks very
you.
much. Good night.
Good night.
I hope you had a nice time, sir, Dr. Kar.
Oh, absolutely.
Alim asked the section. Alim was thinking about his needs when he turns 82. So he asked you the last question.
Jesus.
The planning target, sir.
But it was really lovely experience being with you and able
He
to.
thinks too far ahead.
It's really lovely and really amazed being there and talking about something very close to my heart. Yeah.
Good night. Sir.
Today
Good night,
there
everybody.
is celebration all over India. Still we have
Good night.
we are here enjoying this.
Thank you very
Good
much.
night, everybody. Good night, sir. Good
Thank
night.
you so
night.
much.
Good-
Thank you so much.
Pavan?
Good night, sir. I'll close it from mine.
Sure.